Rheumatoid arthritis basically is a systemic disorder characterized by chronic inflammatory polyarthritis of unknown etiology. And because it is a polyarthritis, that is a primary presenting feature. So, a lot of orthopedic surgeons, as I said, are involved in the management of rheumatoid arthritis, even medical management. Of course, surgical management is primarily the domain of orthopedic surgeons. It involves various organs, including skin, eyes, lungs, and even blood vessels, as has been mentioned by a previous speaker. It is a fluctuating clinical course and unpredictable prognosis. Sometimes the disease burns out early. Sometimes it's got a very fulminating course in some of the patients with gross disability. And of course, it has got a multifactorial pathogenesis. The disease is primarily an inflammatory process, and the outline has been given by previous speaker also, but even at the risk of repeating, I'll still go ahead with it, because primarily there is activation of macrophages because of antigen, which results in inflammatory cytokines released from macrophages, that is tumor necrosis factor, and interleukin 1 is the primary reason, which are the responsible factors for the inflammation. It leads to synovitis, production of collagenase. Of course, collagenase leads to destruction of cartilage matrix. And of course, there is also release of matrix metalloproteinases, which also leads to cartilage degradation. Similarly, in osteoarthrosis also, the inflammatory factors are same, TNF alpha and interleukin 1. There has also been found to be elevated levels of IL-6, IL-17 and MMPs in the synovial fluid. And all these factors are primarily responsible for degeneration or degradation of cartilage, which is the primary pathology in rheumatoid as well as osteoarthrosis, because the damage to the cartilage is there, and that results in degeneration of the joint. Of course, resulting in severe deformities also, specifically in rheumatoid arthritis, because that involves soft tissues also. So, if we see this algorithm, now TNF alpha and IL-1 are the major inflammatory cytokines involved in rheumatoid as well as osteoarthrosis. Now, further what happens is, as has been mentioned earlier also, these factors initiate the activation of nuclear factor kappa B, which goes into nucleus, and then it results in further release of inflammation. And basically NF kappa B is supposed to be an on and off markers for inflammation in the body. And once it is released, it causes damage to the cartilage, and it is therefore due to activation of nuclear factor kappa B that the problems or like rheumatoid arthritis, osteoarthrosis, ankylosing spondylitis, psoriatic or any inflammatory arthropathy, the problem arises. So that has been described as a master switch of the inflammation. And this is the algorithm, that this activation, basically it is done by TNF alpha, IL-1, IL-6, etc. It goes into nucleus, and then that is activated by IKB kinase. It goes into the nucleus, and then it releases the genes encoding inflammatory mediators like TNF alpha, again IL-16 and COX-2 enzymes, which results in release of inflammatory mediators like these and further damage to the cartilage. Now, what are the options available for these conditions presently? We have NSAIDs, we have steroids, we have disease modifying agents, and we have biologicals. A lot of them are effective. They are the only probably in the current scenario, but a lot of these have a lot of problems also. NSAIDs, I think they are the most widely used drugs for these inflammations or these conditions, but they have their limitations also, which are most widely accepted and acknowledged. They are not suitable for elderly patients, they are not suitable for long-term treatment, and they have a lot of side effects, including GI system, renal toxicity, hepatotoxicity, and even cardiovascular risk. Steroids, they are less commonly used now, but the concept is gradually evolving that we should be taking the inflammation, we should be controlling the inflammation by everything that we have in our armamentarium, so that the damage to the cartilage does not occur. Because once the damage to the cartilage occurs, then there is no going back, then it cannot be reversed, and then probably surgery is the only option. So steroids are also being widely used now in the first stage itself, or first line drugs. But again, they have a lot of side effects. I think physicians will be knowing much more than me. Gastritis, ulceration, diabetes, hypertension, osteoporosis, muscle weakness, atrophy, AVN. We have seen AVN of hip quite often with even smaller doses of steroids. I have seen cases of AVN of the hip with even single heavy dose of steroids. There is the only history of single heavy dose of steroid resulting in AVN of the hip, requiring joint replacement at a later stage. So steroids, while they are very useful and effective drugs, are also very dangerous drugs, specifically in these situations. Disease modifying agents, they have become first line drugs, specifically methotrexate in rheumatoid arthritis. They are almost widely used now. Doses ranging from 15 to 20 milligrams per week in divided or single dose. The problem is they are slow in action. It takes quite a number of weeks before they are effective. Though the doses are low, still there are some side effects, and we have to continuously monitor liver functions, blood counts, etc. if patient is on methotrexate or diseases like that, or medications like that. And it is specifically problematic once the patient is a young female and is going into planning a family or having a child. Then they have to be discontinued, and it is not very clear as to how long the side effects could be in those situations. One cannot vouch for that, and they have to be discontinued many months before one plans to conceive a child or start a family. So these are certain limitations as far as DMRD is concerned. Biologics specifically are quite effective, but then there are problems. One of the most important problem in biologicals is they are very expensive drugs. And I think bulk of population, at least in India, is not able to afford those drugs. A lot of them are not even available in India. And of course, there are problems, other problems, even if you start with that. The effectivity is still not that effective. They are injectable drugs. They cannot be taken orally, so patient has a problem taking those drugs also. Of course, there are other side effects reported, like multiple sclerosis or incidence of malignancies following that. Now, because of that, the emphasis is on other areas which can take care of the inflammation part. Because in these conditions, primarily we are taking care of inflammation so that the cartilage is not damaged. And a lot of research has also gone into growth factors. We have in fact done a series of studies involving platelet-rich plasma, specifically in osteoarthrosis. We found it to be effective, but the results are short-term, specifically for osteoarthrosis of the knee, which is the most common condition as far as OA is concerned. But in short term, we have been able to find that the pain scores are definitely reduced, even after 3 to 5 injections in the beginning at weekly or fortnightly interval. But long-term studies are still not there. We tried to study the thickness of cartilage after injections also, but that was found to be not improved following PRP injections, though the pain scores were better, and requirement for analgesics was also reduced. But still, that is again in an experimental stage, or it's not widely accepted, you can say, to have a definitive or a long-lasting effect on these conditions, specifically OA. It has not been used much in rheumatoid arthritis per se. Now, as mentioned earlier also, turmeric has been a product which has been described in Indian medicine system quite way back for treatment of various ailments, including reduction in inflammation. I remember many people telling the patients with trauma that haldi ka lep laga lo to shayad sojan kam ho jayegi. So I think turmeric was known to be a very effective anti-inflammatory drug in Indian medicine system. And we are going back to nature to find out things to take care of the various ailments, specifically the ailments which are there for quite some time. It is a biologically active phytochemical compound. Now, it possesses diverse properties: anti-inflammatory, antioxidant, anti-proliferative, even anti-angiogenic, as was mentioned by previous speaker, though it is not fully established as per his. I have no experience of that. It is supposed to be a nuclear factor kappa B inhibitor. So, the on-off switch that I was talking about, it affects that. It doesn't allow its activation, thereby reducing the inflammation. So that's what it is, the site of action is. It inhibits IKB kinase enzyme, which activates the NF kappa B and thereby reduces the production of inflammatory markers like IL-6, COX-2 and IL-1 or TNF. There have been number of studies, some have been provided in these slides. I have gone through literature. I was not able to do much of the study because I have no personal experience of this in osteoarthrosis or rheumatoid arthritis for that matter. But I tried to search the literature, and there have been number of studies from Europe. There was a study from Netherlands also. Lot of these studies used curcumin in basic form. Now, problem with that is you have to use large amount of curcumin in the range of up to 12 grams per day to have some effect in these conditions. The reason probably is the penetration is poor, absorbability is poor, and it's a hydrophobic compound, so it doesn't attract water and doesn't get absorbed very easily. And consuming 12 grams of curcumin per day has its own problems, and that is why it was not very widely accepted. So the research is now going on to have an extract which is sort of a fine, or you can say concentrated form of the active ingredients. I am not familiar with the process per se, I must say. And that has been made hydrophilic with a better penetration, so that small amount, few milligrams of that is equivalent to 12 to 14 grams of curcumin, which is the basic, you can say, salt or basic product, or haldi you can say. And there have been studies which have shown that it improves the disease activity score, reduces the pain scores, and reduces the requirement of various other drugs, including NSAIDs, including steroids, including disease modifying agents, if they are given in combination. And even there are some studies which have reported that the scores are comparably reduced vis-a-vis NSAIDs or steroids or even DMRDs. And they have quoted some literature in this. There is a 52% reduction in CRP level with curcumin, as have been reported in this study. It is a American College of Rheumatology study. Then there were other smaller studies with a better tolerance, and they have reported very few side effects. Some nausea and vomiting has been reported, but that has also been reported more with the basic product of curcumin, where you had to consume up to 12 grams per day. So that has not been seen with the newer products, which is a refined version of that. And there have been studies in comparison to NSAIDs and other things also, where it has been found to be quite effective. With diclofenac, with ibuprofen, with methotrexate, in combination or alone. There have been a lot of studies. In fact, this is a study which I found to be quite informative. When it was given along with celecoxib, they said that it enhances the action of celecoxib and decreases the need for celecoxib. Similarly with prednisolone also, additive effect. Similarly with methotrexate also. And they have, since the requirement is reduced, so the toxicity of methotrexate is also reduced. And even with US FDA, it is labeled or it is recognized as a safe drug with no noticeable adverse events. It is free from adverse effects on kidney, liver or CVS even after long-term use. Occasional, as I mentioned, mild transient nausea or diarrhea is seen. Now, conventional, as I mentioned earlier, up to 12 grams per day was required. And the newer drugs, basically, it is said that if you start with, say, 50 milligram twice a day, it is quite effective. And then if you require higher doses, you can go up to 400 milligram per day in divided doses. But by and large, most of the patients respond by 100 to 200 milligram per day, which has very little or negligible side effects. But per se, I must admit that this salt is as yet not available in India. Maybe in near future it is available. And we have no personal experience of this in India. To summarize, it inhibits the master switch of inflammation, that is nuclear factor kappa B. It decreases release of inflammatory prostaglandins and cytokines. Monotherapy found to be effective and safe in treatment of rheumatoid and osteoarthrosis as per the reports. Its efficacy is at par with NSAIDs but is with better GI tolerability. When given along with NSAIDs or steroids or even methotrexate, the effectivity is much more and helps in reduction in requirement of those drugs. And unlike biologics, can be given orally, safe, is well tolerated. Regarding expense, I am not sure. Once the drug is introduced, we will all see how costly or how cheap it is. So, thank you very much.